Hi, everybody. My name is Sunil Saith, and I'm a cardiology fellow at SUNY Downstate. And today I'm going to be going over a lecture which I gave previously earlier this month in August of 2022. This is a lecture on cardiogenic shock and hemodynamics in the CCU and mechanical circulatory support. This is designed to be an overview for residents who will be rotating in the CCU and to give an introduction and background in management of this. A little bit of background about myself is that while I am a second-year fellow at SUNY Downstate Cardiology and having done 1 year already and several months in CCU, I've also had experience previously in working with advanced heart failure and doing a non-accredited ACGME fellowship and having some experience with mechanical circulatory support. So I have some background and some experience in managing this. So a little bit of the agenda. This is a QR code to the SCI classifications for cardiogenic shock. First, what we're going to do is we're going to define what is cardiogenic shock. We'll discuss the different treatment options which are available. I'll go over hemodynamics, and then we'll also discuss about mechanical circulatory support as well. So first, we're going to begin with a clinical case here, and this is a 75-year-old female who's in the hospital for 3 weeks because of worsening shortness of breath, worsening swelling of her lower extremities, and changes in her baseline mental status. She reports sleeping in a recliner for the past 4 nights and denies any chest pain. Her past medical history is remarkable for having prior PCI to her right coronary artery. She's on aspirin, Lasix, carvedilol, Entresto, digoxin, aldactone, and metolazone as needed. So these are her vitals. Her examination shows an elevated JVP. She has an S3, and there's ascites. Her extremities are cool, and she's got 3+ lower extremity edema, which is extending down to her knees. These are her labs. And her EKG is normal, and their echo shows an ejection fraction of 20%. So which of the following is the most appropriate initial treatment? Would you increase carvedilol? Would you increase the digoxin, increase her Entresto, or would you start her on dobutamine? The answer here is suggested to start dobutamine. This is a patient who is in cardiogenic shock, and given her low blood pressures, she's hypotensive, so carvedilol and Entresto would not be reasonable options at this point in time. And although her digoxin level is subtherapeutic, the issue here is that she is in decompensate heart failure, as evidenced by her examination that she's volume overloaded. And so the key concept here, this is a question that's been adopted previously, but covers cardiogenic shock. But in the general curriculum for general internal medicine, there isn't much exposure and much management in managing in questions when it comes to managing cardiogenic shock. So, but it's a little bit of background, there. And so what I'm also going to do is I'm going to discuss a clinical case. Excuse me. This is a 75-year-old female with a past medical history of coronary artery disease. She had a PCI to her LAD and RCA, secondary to a prior myocardial infarction that she had back in 2005. There is some question whether or not she has diabetes. Atrial flutter. She has atrial flutter. She's had an atrial clip, but it's not an anticoagulation because of a GI bleed, and she's got severe substernal chest pain and diaphoresis. The patient was brought in ventricular tachycardia, ventricular fibrillation that required shock in the field. So she was at a hospital V through arrest. It's a STEMI notification. It was loaded with aspirin Brilinta. You can see her initial hemodynamics. Some things to point out is that her cardiac output is 2.2, her lactate is elevated at 6.8, and her CPO is 0.36. So what is a CPO? Well, I'll discuss this concept a little bit later, but this is just kind of an introduction if you're not familiar with that. But another important thing I'd like to highlight too is that her cardiac output is 2.2. And so I'm going to make a distinction between cardiac output and cardiac index when it comes to defining what is cardiogenic shock. So the patient underwent cardiac catheterization, was found to have severe triple vessel coronary disease. She had approximately 100% thrombotic occlusion of her LAD. She had patent overlapping LAD stents. Her stent in the RCA, proximal RCA, was patent as well, with some mild disease, mid disease, Circumflex, she had a stenosis, and the ventriculogram showed anterolateral hypokinesis. An Impella CP was placed with improvement in the cardiac output from 2.2 up to 3.2 to 3.4. And so Impella is, again, we're going to talk about cardiogenic shock as well. So Levofed, 20 mics per minute, and heparin drip were added to as well. So what is cardiogenic shock? Well, cardiogenic shock by definition is a cardiac output which is insufficient to meet the body's metabolic demands. This is important to distinguish between the multiple different types of shock, of course. And so many times the consult question comes to cardiology is this patient in cardiogenic shock? So cardiogenic shock is specifically defined as having a cardiac index of less than 2.2 liters per minute per meter squared, as well as an elevated wedge pressure, with a wedge pressure 15 millimeters of mercury or greater. Additionally, you may have the systolic blood pressure less than or equal to 90 millimeters of mercury, or systolic blood pressure change of at least 40 millimeters of mercury from the baseline, suggestive of relative hypotension, or mean arterial pressure 60 millimeters of mercury or less for at least 30 minutes. Additionally, anything in which supportive measures to maintain the systolic blood pressure to at least 90 is also sufficient to meet the definition of this as well. Additionally, the cardiac power output, which is the CPO, less than 0.6 watts, is specific for actually the increased high risk for in-hospital mortality. This is actually a correction, is that whether or not this is actually, if it's actually cardiogenic shock or not. It's the product of the mean arterial pressure and cardiac output divided by 451, which I'll discuss again a little bit later. Also, you may have signs of end-organ hypoperfusion by definition of shock, such as the heart, lungs, kidneys, brain. And it may require, it requires clinical and biochemical and hemodynamic parameters to guide resuscitation. Now, one of the challenging things when it comes to cardiogenic shock, unlike surviving sepsis, is that there are some debates in question about looking at many guidelines and looking at many different documents about what are the optimal hemodynamic and perfusion targets. It's not really precisely defined and requires further study. And a lot of this has to do with the fact that cardiogenic shock is a multifactorial etiology, which we'll discuss as well. So with the complexities of cardiogenic shock, this is from a cardiogenic shock institute in Detroit, Michigan. Acute myocardial infarction shock mortalities remain unchanged, unfortunately, over the last 20 years. And you can see that the number of cases on the left of acute myocardial infarction in cases per year have been going up, and the mortality is a high in hospital mortality during acute myocardial infarction, cardiogenic shock specifically, which is hovering around 50%. So it is a very challenging area and does require a lot of diligence and awareness. As I say, time is tissue, especially when it comes to acute myocardial infarction. So what I'm going to do is discuss a little bit about the etiology of cardiogenic shock and acute myocardial infarction mechanical complications. So that's the first common thing that we often see, as mentioned before. So people who are coming in with an MI may end up in cardiogenic shock. Now that's not always a STEMI. You may also have non-ST elevation MI as well. However, there are other etiologies besides myocardial infarction which could very well play a role. It's be generally due to left ventricular dysfunction, right ventricular dysfunction, acute mitral regurgitation, a ventricular septal defect, pericardial tamponade, or free wall rupture. So acute ventricular failure. Other causes exclusive of coronary disease include myocarditis, transplant allograft rejection in people with prior heart transplants, a rapidly progressive dilated cardiomyopathy, Takotsubo cardiomyopathy, and the LVAD dysfunction. Other etiologies of cardiogenic shock include acute and chronic progressive heart failure, valvular disorders, which could be acute aortic or mitral regurgitation, critical aortic stenosis, And then there are other causes too as well, which can include septic shock with left ventricular dysfunction. So you can have a mixed shock picture. And not one etiology of shock is necessarily present. You may have multiple etiologies which are present at the same time. And then also pulmonary embolism and myocardial contusion. So the focus here, inotropes act on the increase in cardiac output. Vasopressors act on systemic vascular resistance. So the mean arterial pressure is the product of the cardiac output and the systemic vascular resistance. And so this is an important distinction when it comes to understanding the etiology of shock and what you're looking to treat. So inotropes and vasopressors. So inotropes will increase the cardiac output. Vasopressors will increase vasoconstriction, which increases the systemic vascular resistance. Some examples of inotropes include dobutamine and milrinone. Vasopressors may include norepinephrine, phenylephrine, epinephrine, and vasopressin. And dopamine is one which has vasopressors with inotropic properties as well. So last year there was a trial which examined which inotrope is favorable to use in cardiogenic shock. Is it milrinone or is it dobutamine? And so this was a comparator where they compared milrinone to dobutamine in cardiogenic shock. It was a double-blind randomized controlled trial. And what they did find essentially was that there was no between group difference between milrinone and dobutamine in the important secondary outcomes. So really, in terms of like what agent to use, different agents call for different circumstances. Now, dobutamine can be useful in initiating when, but the other thing though is that if someone is having difficulty in weaning off inotropes, then you may have to switch over to milrinone, and that has been something that we've had to do before in people who are going home with palliative inotropes, because what can happen is that with dobutamine is that they may develop tachyphylaxis. Additionally, you may also have hypotension, which can result from dobutamine. Milrinone can also cause hypotension too as well, but again, the agents, it's just the disease process and trying to strike the right balance in what to do. This was a subset in the DOREMI trial where they found that lactate clearance is a surrogate for mortality in cardiogenic shock, particularly. And what they found was complete lactate clearance was the strongest predictor of survival time points in the first 24 hours. So cardiac index was a concept that I mentioned earlier. We reported on the cardiac output, which was 2.2. However, cardiogenic shock is defined as the cardiac index of 2.2. And cardiac index normalizes the cardiac output, the body surface area. So there are two different ways in which one can measure it. It can be measured through thermodilution, or it can be measured through Fick. What is thermodilution? Well, I'll go over the Swan-Ganz catheter in a moment. The Swan-Ganz catheter is it has a port. You could imagine that you have a cold can of soda, right? And you have it in the right atrium, and it's traversing through to the pulmonary artery. Now, anytime you have a cold can of soda and it's passing through any kind of substance that's warmer than that, you can expect that the can of soda is going to get warmer. But the question is that how much will it warm up will depend on how quickly that can of soda is flowing through from the right atrium to the pulmonary artery. And so obviously if the cardiac output, if it's slow, it's going to take longer, and therefore there's going to be a bigger temperature drop. Now, one of the issues with thermodilution, of course, is that it can be confounded by tricuspid regurgitation. You can imagine that the distance is going to take longer for it to travel, and so as a result, with tricuspid regurgitation, one of the limitations of thermodilution is that because of TR, it may underestimate the cardiac output. Now, the Fick equation, on the other hand, on the right here is the cardiac index. This is something that is measured by the oxygen consumption. It's a modification of Ohm's law, and you can see it's the oxygen consumption on the numerator divided by the hemoglobin multiplied by the constant 1.34, and it's the difference between the arterial oxygen saturation and the venous oxygen saturation. Now, one simplification of this is a rough estimate that one can use is that you can imagine at the top the oxygen consumption index being 120 to 140. Let's just say, for the purposes of this illustration on the right, let's make the numerator 134. And then for the purposes of this illustration too, we're going to say that hemoglobin is assumed to be 10. So what you're going to do is 134 divided by 10 multiplied by 1.34 results in a simplification where the cardiac index can be approximated by taking 10 divided by the SaO2 and the SvO2. I encourage you to, unfortunately with this is that when I demonstrate this is that in the CCU is that I actually wrote this down. So, but what you can do here is the numerator, take 134, divide by 10, multiplied by 1.34, and you can see the simplified equation. When you simplify for that, this can give you a rough estimate. So the cardiac index is 10 minus the SaO2 and the SvO2. And so if you have the mixed venous oxygen saturation, you can get an estimate of what the cardiac index is. So essentially 10 divided by whatever that difference might be. As mentioned earlier, the cardiac power output of less than 0.6 is the strongest correlate for in-hospital mortality in cardiogenic shock. So cardiac power output is this was based on the shock trial. Mean arterial pressure multiplied by cardiac output divided by 451 to convert this into watts. And so this is an important measurement in measuring the prognosis of this. Now what I'm going to do is I'm going to go over what is a Swan-Ganz catheter. This Swan-Ganz catheter is something that we do use still, even though that it has kind of fallen out of favor from the 90s when it comes to shock overall. However, specifically in cardiogenic shock, it can be useful. And so what you can see on the image on the left here is that the balloon is inflated. So you have a little balloon at the end, and then you have the tracing on the right. And the tracing on the right, you can see that in the right atrium, and now it's in the right ventricle. And when it goes in the right ventricle, it has a step up, go into the right ventricle. And then once it gets into the pulmonary artery there, you have a step up there. And then now it has the wedge. So what happens, now the balloon's going to deflate. And look at the tracing on the right, you can see that you have the waveform. When you inflate the balloon, you're going to see that you're going to get the wedge pressure. Now the wedge pressure is a measure of the left atrial pressure. There are no valves between the left atrium and the pulmonary artery. So the idea here is what you want to try to do is assess what the volume status essentially is of the patient. Now in the ESCAPE trial, we did find that there was a 1-to-2 relationship. So you can get a rough estimate of what the volume status is essentially by from the left atrium and the right atrium based on the JVP. And so if it's a 1-to-2 relationship, what you can see is that a JVP of 7 may approximate a wedge of 14. So it's not a hard set guideline because it could be a bit tricky, and there are other things that might explain why the left atrial pressures might be elevated, including valvular disease. So if you have mitral stenosis, your left atrial pressures are going to be elevated, obviously. And so that's an important factor to consider is whether or not there's a presence of concomitant disease as well. So normally pulmonary pressures, there are different ways of remembering this. So how do you remember this? Well, some people use the rule of 5. So in the right atrium, it's 5. In the right ventricle, it's 5 times 5 is 25 over 5. And so the way you can remember that the denominator is 5 is think of this conceptually. When the tricuspid valve is open, it's essentially one continuous conduit between the right atrium and the right ventricle. So one would expect in diastole that the pressures will be equal. And if the pressures in the right atrium are greater, the valve will be open. But when the when the tricuspid valve closes, then the pressures in the right ventricle are greater than the right atrium. Similarly, you can make the same conjecture on the pulmonary artery. So 25 over 10. So 5 times 5, and then 5 times 2. And then the left atrial pressure is estimated to be 10. Now 5 is again, remember that there's a range. So anywhere from 3 to 8. So 5 is the middle, 3 to 8. 25, it could be anywhere from 22 to 27. And then it's the same sort of thing. Another quick way that you can remember it, if you're familiar with U.S. currency, is quarters, nickels, and dimes. So you can just think of that this way: that you have a nickel, 5 cents is a nickel, 25 cents is a quarter, 10 cents is a dime. So this is a kind of a quick way that you can remember this. So what do you need when you're doing a Swan-Ganz catheter? So what you need is a 9 French cordis. You need a 7.5 French Swan kit, which is pictured here, and a right IJ kit, and the bedside ultrasound as well. Now, due to the risk of complete heart block, a Swan-Ganz insertion should occur under fluoroscopy in this specific circumstance. So if you see this EKG, which shows the left bundle branch block, you should think about fluoroscopy. The idea here is that anytime you insert a catheter into anywhere where it can go, is that it can always perforate something. So that's something to be aware of. Now what I'm going to do is talk about mechanical circulatory support options. Talk about three options: Impella, intra-aortic balloon pump, and the VA ECMO. These are things that you will see in the CCU. There are other agents too as well. It depends on the institution, the familiarity with the different agents. But we're just going to go over a little bit about this. So one of the things that I saw here, this is a picture of Big Pappy from the Boston Red Sox. And so PAPI is the pulmonary artery pulsatility index. And so what the purpose of this is to think about the right side of the heart. The pulmonary artery pulsatility index is essentially the difference between the systolic pulmonary pressure and the diastolic pulmonary pressure over the right atrial pressure. It's a function to assess whether or not you need right ventricular support. One of the trickiest things to manage with cardiogenic shock, and unfortunately in the scope of understanding this, is that the right ventricle is essentially everything. You can support the left ventricle with all kinds of devices, but if you can't feed the left ventricle, you're in trouble. So if the cardiac power output is less than 0.6, meaning that there's a high risk for mortality, consider the pulmonary artery pulsatility index. And if the pulmonary artery pulsatility index is less than 0.9, then you have to consider RV support. And this may include devices that's available in the CCU, like the Impella RP. Again, this is an overview of the different mechanisms. You can see that there's intra-aortic balloon pump, Impellas, the tandem heart, and the VA ECMO. So there's a lot of different, the point being here is that there's a lot of different devices which are available, a lot of armamentarium. It's good to understand what exactly that you're looking at here. So this is the intra-aortic balloon pump. And so you can see that what I'd like to highlight here is that the bottom of this balloon pump is above the kidneys. If it's below it, it may obstruct flow to the kidneys. And then the top of the balloon is distal to the subclavian vessel. So the idea here is that the balloon inflates in diastole and then deflates in systole.
That leads to increased forward blood flow. These combined actions result in a decreased myocardial oxygen demand and increased myocardial oxygen supply.
So what you can see there again is that it inflates in diastole, which increases the coronary perfusion. So in diastole, the aortic valve is closed, and the coronary cusps will increase the pressure when it inflates. It deflates in systole, which will help augment the systolic blood pressure. It adds approximately 500 cc's to stroke volume, according to some estimates. And so one of the things is that you used to see this a lot more commonly, but because of the recommendations that were about 10 years ago, it's actually been downgraded to 2A recommendation. And many times we look at the Impella if we're looking at improving the cardiac output. If the cardiac output's good and we're just looking to, in high-risk PCI cases, and we're looking to increase coronary pressure and to unload the left ventricle, and this does a great job of helping to unload the work. And so I apologize, I noticed that in the recording of this video is that it did, the audio narration was also coming across too as well. But some important things just to know: indications, acute coronary syndrome and its complications, cardiac and non-cardiac surgeries, heart failure complications, and of course the idea here is that this is the prerequisite is that the aortic valve has to be closed. And if the aortic valve is not closed, then you have you may have aortic regurgitation. And obviously, that's not good if the balloon's inflating and it's increasing the back pressure. It's going to worsen the aortic regurgitation. So these are some tracings, as you can see that the in the electrocardiogram below, that the tracings essentially it inflates in systole and inflates in in diastole and deflates in systole. So the important thing is that you have to gate this to the electrocardiogram. You have to gate this to the appropriate cycles. And the thing to highlight here is you have the unassisted systole, and then you have the diastolic augmentation increasing the pressure, which results in increased coronary perfusion. And by decreasing the end, the systolic pressures, the assisted systole, you can see on the far right is that this is lowering the pressures, which is helping to unload the left ventricle. So talk a little bit about ECMO, extracorporeal membrane oxygenation. Now, since this lecture is focused on cardiogenic shock, we are going to be talking about VA ECMO, so veno-arterial cannulation, which provides both gas exchange and circulatory support. This is different from VV ECMO, which is veno-venous, and is used for purely for worsening respiratory failure. So the indications for ECMO, again, will be cardiogenic shock, plus or minus MI. Could be a number of other conditions as we discussed before. Some contraindications. Again, the idea here with ECMO is that it's not a permanent solution, and what it needs is a careful consideration about what your next steps are. Maybe that may be a transplant. It could be a LVAD. It could be any kind of bridge to it, what's called bridge to decisions. So contraindications. Again, the idea is that, well, what is the game plan? Someone with malignancy, severe brain injury, aortic regurgitation, or unrepaired aortic dissection, these are some of the things that you have to think about when you do this. Just a little bit about, given in the last couple of years with cardiogenic shock, is that there are different stages of cardiogenic shock. So you have A, at risk, or hemodynamically stable patient, not having any symptoms, but is at risk for development. So if they have a large MI or decompensated heart failure. B is the beginning stages of shock. Now, not necessarily, the formal definition of cardiogenic shock is, again, that they may have the cardiac output insufficient to meet the demands. Now, one of the things, though, is that you may have some perishock states where the lactate may not be elevated. They may not be quite yet in the state of shock, but they are heading towards that. C is classic. Patients who obviously have, again, meet the definition of cardiogenic shock. D is deteriorating, so it's unfortunately that when you have therapies, that it doesn't seem to be getting any better. And E is extremis, refractory shock or impending circulatory collapse. And so it's important to think about these stages. I think the reason for this classification schema is designed to get people to start thinking about earlier referral, which is something, the earlier the better. If you can identify what's going on and you know what you're faced with, it's a good idea to think about these things early, because time is tissue, and there's many different things that say with the golden hour, maybe like a golden day. So there's a lot of different things. So sometimes you may need to really consider this. So I'm going to just go over a case, follow up the case that I had presented at the beginning of this lecture. And so this was a case, I remember, as I mentioned, about the subset of the Do-Re-Mi trial, that lactate, unfortunately, with this patient, you can see that the lactate remained elevated. I was actually on call this night when this happened, and what happened, unfortunately, is that the patient continued to deteriorate despite the best efforts, and lactate remained elevated. The patient went into worsening metabolic acidosis. Patient became hypotensive. The etiology was unclear, whether or not there was a septic picture involved. A number of different issues, and unfortunately the patient expired the following day. So again, the reason for this case is to highlight the high mortality of cardiogenic shock and why it's important. And so the case actually happened the week that I was planning to give this lecture, and so I included this. And I also did have another case as well, in which a patient had a Impella RP for right ventricular failure that unfortunately also passed away the following day after my lecture was originally given to as well. So in essence, I hope that you have found this helpful for cardiogenic shock. It's important to think about these concepts. Some of the equations and some of the other things do require some practice. I have found that it's very helpful when having Swan-Ganz and calculating a cardiac index and using the heuristic shortcut formula of 10 divided by the mixed venous difference between the arterial and mixed venous oxygen saturation. So I hope you found this helpful, and if you have any questions, please don't hesitate to reach out. Thank you.